KNH is Dr. Nafula. So Dr. Nafula, maybe you can take us away with the Nani. Then as usual, we have our Q&A at the end of the session, and you can post them at the Q&A. Thank you very much. Go ahead, Dr. Nafula.
Good afternoon, everyone. I hope you can hear me clearly. It's yet another lovely afternoon for us to talk about palliative care. And today we want to talk about the World Hospices and Palliative Care Day. Those of you who follow the KNH page on social media, I'm sure you've seen a lot of videos and a lot of hashtags about palliative care this week. And we would like you to know why we are making a fuss about palliative care. Now, the theme for this year for World Hospice and Palliative Care Day is Leave No One Behind, Equity in Access to Palliative Care. So this afternoon, my presentation will be about 30 to 40 minutes. And we are going to look at the history of palliative care, how palliative care originated, what has been happening in the world, in Africa, in Kenya, in Kenyatta. Then we'll discuss about the World Hospices and Palliative Care Day, and also just what we are doing as the KNH fraternity for this day in 2021. So as you've heard from our previous presentations yesterday and on Monday, palliative care is an approach that improves the quality of life of patients and their families as they face the problems associated with life-threatening illnesses. So we do this by preventing and relieving suffering, by identifying problems early enough, assessing them holistically, and treating them where possible. So we treat physical problems, psychosocial, and spiritual problems that arise with having a life-threatening illness. So palliate comes from a Latin word palliare, which means to cloak or to cover. So palliate means to make less severe or to lessen the severity of an illness without providing cure. Therefore, palliative care treats, prevents, or relieves symptoms of a serious or chronic illness, but does not cure it. Therefore, the patients who are referred for palliative care, that's why it's called care. They've been referred for care, not cure. They are referred to us so that we help the patient and the family to deal with the problems that are coming with having to live with a life-limiting or a life-threatening condition. So in short, palliate means wellness. So our focus is on making the patient enjoy their life, no matter how many days, hours, months, or years are left. Our work is to help them to be well enough to enjoy whatever time is left. So palliative care started out of a hospice movement. So the first time that this word was in existence, or this care was in existence, is in 1843. That is a long time back. That's when the first hospice in the world was ever established in France, then followed by one in Dublin in Ireland. And then in 1905, we had a hospice in London. So initially, the hospices were created for patients who were dying and they could not afford treatment. So the first hospices were coordinated largely by the church, the Catholic Church being a key player, because like the hospices in Dublin and London, it's the nuns who used to take care of the patients. So they felt sorry for the patients who were dying and had no family to take care of them. They had no finances and they had a lot of suffering. So hospices were created for these patients. Now, the modern day hospice or modern day palliative care came into existence in 1967, largely looking at the models of these hospices. Because the nuns who were providing care, some of them were not healthcare providers. They were not trained, but they were just doing it out of compassion. Now, from 1967, healthcare providers, nurses, doctors started getting involved in taking care of the dying patients. The term palliative care was coined in 1973 by Dr. Balfour Mount. On your screen, he's the one closest to the KNH logo. He's a urologist by profession and he's still practicing in McGill University in Australia. So he's the first person who came up with this term of palliative care. And palliative care became recognized as a medical specialty in 1987. Started off in the UK. St. Christopher's Hospice is on my far right on the screen. That is the first modern day hospice that set up palliative care now as a medical service and not as a charity or sociable service. In Kenya, it was recognized as a specialty in 2015, and the first doctor to be registered as a specialist is right here in the middle. His name is Dr. John Weru, and he's practicing in Aga Khan University Hospital. Some of you might have encountered him. Now, in 1948, Dr. Cecily Sanders initiated the practice of modern day palliative care. And how she did this, she was working with dying patients, and she started off as a nurse, then she decided to be a social worker, then she studied medicine. So while working with cancer patients in the hospices, this is before St. Christopher's was established, she realized that there's a lot of suffering that is associated with having an illness like cancer. And she documented a lot of her work that these patients were having physical problems, social isolation, psychological problems, spiritual problems. And she worked hand in hand with a very famous psychiatrist. So Dr. Cecily Sanders' picture is the one next to the library, and Dr. Elizabeth Kubler-Ross is the one who is standing. Elizabeth Kubler-Ross was a psychiatrist, and she did a lot of work in the psychological adaptation to dying. You might be familiar with her model of grief. It is used a lot, where we talk about the 5 stages of grief, from denial to anger, to shock, to bargaining, to accepting. And it's a model that we have largely come to use, just not for death and dying, but generally when we are dealing with any loss or bad news. So Elizabeth Kubler-Ross and Cecily Sanders worked together on a lot of projects, and they came up with a concept called total pain or total suffering, which is where the holistic assessment of patients in palliative care originated from. That when you are assessing a patient, don't just focus on the physical problem that has brought them to hospital, especially when this patient has a chronic life-limiting illness or a progressive illness, because the patient, apart from just their physical problems, lives with a family. There's a way the family is interpreting the illness, there's a way they're treating the patient, and all these things are culminating into anxieties, fears. So our work is actually to assist the patient. Now in Africa, the first hospice was established in Zimbabwe called Island Hospice in 1980. After that, we had a Hospice Palliative Care Association of the South African region formed in 1987. And in East Africa, proudly, Kenya was the first one to have a hospice. This was Nairobi Hospice that was established in 1990 by Dr. Bridget Sirengo, whose picture is projected here. She was chosen to set up these services, and the ministry facilitated her training, and she came back and established our first hospice. And Uganda followed suit by establishing Hospice Africa Uganda in 1993. And in 2002, we had an African Palliative Care Association that now seeks to regulate the practice of palliative care within the African region. Now, in the West, around the year 2000 is also when the International Association for Palliative Care was being formed. And the practice of palliative care has picked up since around the time when it has become a specialized field, and we have formal training programs. And we also have International Children's Palliative Care Network that was established in 2005. Now, all these associations help us to actually keep up to date with what is happening. And the World Health Organization plus the International Association for Hospice and Palliative Care, they have manuals that we use in resource-limited setups in the areas that have resources, so that our patients are able to get the care that they need, the care that they deserve, and in a timely manner. Now in Kenya, Nairobi Hospice, as I've mentioned, was established in 1990. Then in 2005, Dr. Zipporah Ali pioneered the establishment of the Kenya Hospices and Palliative Care Association. And part of their mandate has been to train healthcare providers in palliative care, both short-term, long-term trainings to integrate palliative care into our mainstream healthcare and even to integrate it into our curriculum for undergraduate training and basic training, so that the healthcare providers who are qualifying have an idea what palliative care is, when patients should be referred to palliative care, and what we are doing for them. So we are proud to say that 65 centers around the country are offering palliative care services. We still have a shortage of specialists because the medical specialists in palliative care are only found in 3 centers in the country, although we have other healthcare cadres who are trained in palliative care and are offering the services to patients. So our patients are still suffering because, of course, out of the 65 centers, if only 3 are having medical specialists, it means even these other 65 centers are likely running on very low staff. You'll find most centers are being run by 1 or 2 nurses, or at most they're only having 3 staff, but they're catering to a lot of patients. Now let's come home to Kenyatta. I don't know how many of you know where the Pain and Palliative Care Unit is established, but currently we have moved to ground floor opposite the renal laboratory. We are sharing a wall with GFD, the oncology ward. So our palliative care unit, Pain and Palliative Care Unit, was established in 2007 by Dr. Esther Munyoro. She has done amazing work in Kenyatta to ensure that patients who need palliative care can be seen in a timely way. And what we are offering in KNH is hospital-based palliative care. I will discuss about the model so that you understand how it's a bit different from what hospices are doing. So currently we have 7 staff, 1 consultant, 1 medical officer, and 5 nurses. And we serve at least 2,000 patients in a year, both outpatient and inpatient. That's on average. And they are both adults and pediatrics. So we see patients across the hospital, and we are also involved in a lot of protocol development that will improve the experience of our patients as they come through the corridors of Kenyatta. So who needs palliative care? That's how palliative care started. But as we've said, it started only for patients who were dying and because they were poor and could not afford to go to hospital. But with time, we've come to realize that other patients also need palliative care, because the model of palliative care is a holistic approach. It's a teamwork, and it's really the model that we should be picking up for patient care, especially as we strive to make KNH a patient-centered hospital. Now, 56.8 million of the world population need palliative care. That's a lot of people. And most of these people are living in middle and low income economies like Kenya. 7% of them are children, yet 42% of countries lack any initiative in palliative care. Even in Africa, you've heard the countries we've mentioned. There are some countries in Africa that do not have established palliative care services. They do not have providers. So our patients are still suffering. Even in Kenya, where we have providers, the patients are still being referred late. And sometimes actually, as we've said, the providers are few. So not all patients are able to get palliative care. So when we look at a way to categorize who needs palliative care, the simplest way is to look at illness trajectories. What are we expecting from certain diseases or certain diagnoses? So among adults, we have frailty. Frailty comes with increasing age, which means the patients have comorbidities. They are likely to suffer many years of suffering with severe impairment. And some of the diagnoses that we deal with at this point include stroke, dementia, multiple comorbidities. And these patients are in and out of hospital a lot. They're in and out of hospital a lot of times. Sorry. We then have terminal illness. Terminal illness, like cancer or end organ damage, the patients tend to suffer for a short period of time, but it's an intense period of rapid deterioration that comes with a lot of pain, a lot of suffering, a lot of anxiety. So generally you find these are the patients that are often referred to us because their prognosis is quite poor and quite easy to predict. Then for patients with organ failure, they are again in and out of hospital a lot with serious prolonged disability. These are patients who spend 50% or more of their time in bed. They are not functional. They need a lot of support from their families. Now, for patients who have sudden death, this is a fatal diagnosis. There is limited or no time for care. So these ones do not benefit much from palliative care because they arrive in hospital, a diagnosis is established, and some of them die within days or hours of arriving in hospital when we are yet to even establish what is going on to be able to give them good care. Now, in the olden days, palliative care was reserved for end-of-life care or for a point where cure was not possible. Now, I want us to look at this model to understand what we're trying to communicate today, is that palliative care is needed throughout the course of an illness, from the time of diagnosis all the way to death and bereavement. So the statement of "there's nothing we can do for you" is not a statement we like to hear, because there's always something we can do for the patient, for their family. Even after a patient dies, that family still needs some bereavement support, and we can still be able to offer that bereavement support. We can offer them a listening ear, even just listening to them as they mourn or they cry or they vent out their frustrations. That is still something you can do. So just not being able to cure a disease does not mean that we have failed the patient or that the system has failed the patient. There are some diseases that are actually incurable from the time of diagnosis. So the model we are encouraging is to have palliative care alongside curative care. Not that we do curative care, and when curative care fails, then now is when we send the patient to palliative care. Because what happens when patients are referred in that fashion, when they come to us, they actually say, the doctors have given up on me, so they've sent me to palliative care. Now, when we start palliative care at the time of diagnosis, when things change, for example, when someone is diagnosed with, let's say even a liver disease, then now they're developing liver failure. From the time of diagnosis, if the palliative care team has already started counseling the patient, when the patient develops liver failure, we build on to the discussions we've been having, that you had this disease, it's incurable, now you've developed these complications, and now we are changing our goals of care because we cannot cure you anymore. We are now going to focus on making you comfortable. But when we are making that shift, now that's a smooth transition. When we are making a shift from curative care to palliative care, it means now there is no role for curative care, so you go into palliative care. So there we make our patients very hopeless. We need to maintain hope for the patient. Even when they have a terrible diagnosis, we need to maintain hope by reassuring them that there's always something we can do for them. Yes, we cannot cure your disease, but we can take away your pain. We might not cure your disease, but we'll help you get discharged out of hospital, go get settled at home. We teach your relatives how to take care of you at home, and we follow you up from home. So helping patients to set their goals in terms of treatment goals, expectations is part of a huge work that we do in palliative care. So what we should remember is that palliative care plus curative care is one model, and sometimes we can do palliative care alone when curative care is no longer helpful. But the point of initiating this palliative care is what is very important, because as clinicians, as nurses, as specialists, when we sit in a clinic and we see patients, even when you're sending a patient for a scan, for example, you can already predict, or you already have an impression of the kind of diagnosis you're going to get when they bring back your results. So we should start linking them up to the necessary support from the word go, so that our patients can be able to live their life to the full. So palliative care is offered as a team, And the team starts with the patient and the family. If there is no patient and no family, then we don't have anybody to take care of. So our focus is really patient and family centered. Remember, even when we are having meetings with families to discuss with them about the illness of their patient, about goals of care, about resuscitation, you should remember that the patient is the most important person in this team. Communicate with the patient always. Let the patient know their diagnosis, let the patient know their prognosis, let them know the treatment options, because it is their right. Seek consent from the patient to go and discuss with their family. Don't call their family and start divulging information to them that you have not even divulged to the patient. So teamwork includes us involving the patient and family. Then of course, everyone has a role to play in making the patient's life better. So we work with physicians, surgeons, the primary doctors, the medical specialists. We work with the nursing team. We work with allied professionals, being nutritionists, occupational therapists, physiotherapists, psychologists, chaplains, social workers. So the needs of the patient change from time to time, and we should also be able to adjust the interventions we are giving to suit the needs of the patient at that particular time. Palliative care is provided wherever the patient is. So what do I mean by that? Now, the models of providing palliative care that have been approved worldwide include a hospital-based approach. So a hospital-based approach is where patients come to an outpatient clinic, or we assess them in the inpatient setup, and we have a mobile consultation team. For example, in KNH, we have a mobile consultation team. What that means is we see the patient wherever the patient is. A consultation is dropped to us, and we are able to go and assess the patient where they are, and whoever needs to help us in managing that patient, be it a chaplain, a psychologist, a medical specialist, we then call them in on board to help us manage the patient. Now, our hospice-based care also has outpatient and inpatient approaches, where the patients come to the clinic, and sometimes some hospices have beds for admission, and hospices generally, admission criteria for many hospices in the world, the ones with inpatient, they look at patients who have a poor prognosis or are in the terminal phase of their illness. So the family is not able to take care of them at home, and this patient cannot be in hospital. So the hospice serves as the in-between to provide end-of-life care. Now, unfortunately, again in Kenya, we only have 3 inpatient hospices with a total bed capacity maybe of 150 for all the 3 of them. One is in Limuru and the other 2 are in Eldoret. So that means our patients can only be either in hospital or at home. And sometimes we are not able to give them the care they deserve, especially where patients are not very keen on having aggressive care. We are not able to do that because the way our hospital setup is, we are not able, for example, to be very flexible and say you have 3-year-old children and you would like them to see you. Someone is in end of life. It is not practical. For example, in Kenyatta, visiting age is 12 and above. So we are not able to meet the requests of our patients. We are able to do the best to our ability. The next is community-based care, where we do projects with the community. So community-based palliative care focuses on patients who are at home. So there are models for home-based care where patients are visited by palliative care trained personnel at home, and they do sometimes clinics in the community once or twice a week. And this is the model of care that Nairobi Hospice is using at the moment, to see patients in the community, to have community outreach programs, so that those patients who need palliative care and are not able to come to them, to the outpatient, they are not able to come to us in Kenyatta, they can still be seen at home. And many hospices in Kenya are actually using this community-based approach to ensure that the patients who need palliative care are not left out. So let's look at the services that are offered within palliative care. So some of these services we are offering them, some are yet to be developed or established, but most of these services cut across. I can see 11 raised hands. Is there any issue? Okay. Please type your question to the chat. We'll be able to respond to you as we go along. So the first major thing that we do is to manage the distressing symptoms that have brought a patient to hospital, including pain. Our casualties and accidents and emergencies are filled with patients who some of them have advanced cancer or advanced illnesses, and they'll be in and out of hospital because of pain, because of bleeding, because of dyspnea. So part of our big work is to manage these symptoms. Remember, we said there gets to a point where curative treatment is not working, or sometimes there gets to a point where the curative interventions need to be withdrawn because they are not offering any benefit to the patient. So at this point, the focus is on managing the symptom. If someone has advanced cancer, they have pain, and the cancer cannot be treated. So there's no role for chemotherapy, there's no role for radiotherapy. We are not going to leave that patient in pain indefinitely. We need to manage their pain. They've come with dyspnea, we need to manage it. We'll admit them maybe for a few days, but when we are discharging them home, what is the follow-up plan? Because we know now the curative part of their care is not ongoing. Another aspect is advanced care planning. Advanced care planning means that we discuss with patients about their preferences for end-of-life care and for conditions where there is an emergency and the patient is not able to communicate for themselves or they are too sick to communicate. So advanced care planning is where issues like do not resuscitate come in, issues of preference of places of care come in, and even naming a medical proxy. The practice in Kenya has been to ask the patient who is your next of kin, and when the patient is not able to communicate, you automatically assume that that next of kin is the medical proxy. But we hope that this will change with time as we are developing advanced care plans for our hospitals, and eventually we will have a policy for the country and legal framework for which to do advanced care planning, so that the patient actually has a right to tell us who is their decision maker. We should not just be assuming, even sometimes the relatives who have brought the patient to hospital, we should not assume that they're the ones to make the decisions for the patient. We do not know which relationship they have outside the hospital. We do not know whether these people have the best interest for the patient at heart. Only a patient can tell us, this is the person that I give authority to make decisions for my health. We also do end-of-life care. As we have mentioned in the last presentations, and we will keep emphasizing, palliative care is not equivalent to end-of-life care, but end-of-life care is part of palliative care. Then we do cancer care. So a lot of our patients have cancer, and we help them with the support that they need, physical, psychosocial, spiritual support as they go through their treatment. And some of these patients, we actually discharge them from palliative care. It doesn't mean that once a patient is referred to us, then they are going to be with us indefinitely or until they die. Sometimes we finish our aspects of care, we have managed their pain, their disease has been treated, we discharge the patient from palliative care. Then we have geriatric care. This is care of elderly patients. As we mentioned, one of the disease trajectories was frailty, where people are growing old and developing all sorts of complications and problems, and some of their relatives don't know what to do with them. So we help them to know how to take care of these patients. We also offer spiritual and emotional support, and part of the videos that you'll see coming up is from our chaplaincy unit, as they explain to us what spirituality means, what it means to the patient, and what kind of support they actually offer our patients. It's not just about saying a prayer with a patient, but it's about understanding how this journey of illness has affected them and what meaning it has given to their lives. Then we also do psychological support. And again, this is done by the relevant people who have the necessary skills to offer that support. I'm a doctor myself, I'm not a psychologist. So the best I can do is maybe to educate the patient on the issues around their disease, around their treatment, around their prognosis. When it comes to actually doing the full psychological assessment and helping this patient to adapt to their illness, I still need a psychologist to do that. Sorry. Now, the World Hospices and Palliative Care Day is a day for us to talk about palliative care. Now, we take advantage and talk about palliative care the whole week because there are many aspects of palliative care that need to be talked about, and it's not possible for us to do it in a day. So the first celebration was done in 1989, and it was called Come and Sing. So it was a concert to raise funds and public awareness for the Princess Alice Hospice in UK. But then it became a unified day of action to celebrate and support hospice and palliative care around the world. So the Come and Sing did not disappear. It was renamed Voices for Hospices, and it takes place every 2 years where we have concerts where people sing, and the funds that are raised go towards supporting hospice and palliative care projects. Unfortunately now, because of COVID, some of these events have been put on hold, but the Voices for Hospices in Kenya happens at Bomas of Kenya. So the aims of this day is, first of all, to share our vision of increasing availability of hospice and palliative care to the patients who need it, so that they can get this care on time, and we can actually put a smile on the patient's face and the family's face. We also raise awareness and understanding of the needs of patients and families as they live with life-limiting illnesses. And another aim is to raise funds to support and develop hospice and palliative care. So some initiatives that happen around this time are for fundraising, and all these funds go towards either supporting the patients or supporting training so that we can have more skilled personnel to offer these services to patients. Hats and Masks On for Children is an activity that started in October 2013 as part of the World Hospices and Palliative Care celebration. It's an initiative of the International Children's Palliative Care Network. And as you can see on the logo on my right, it's to raise awareness of children's palliative care, one heart at a time. So what we do is to wear a hat to work, and you're wearing a hat and taking a picture to say that you support children's palliative care. So apart from just raising awareness, the initiative is also to raise funds to support children who need palliative care and to raise funds for training personnel on children's palliative care. So since 2013, every first Friday of October, palliative care providers working with children wear a hat to work to raise awareness for palliative care for children. This is part of our team here in KNH. As you can see, last year we were looking very beautiful and handsome in our hats and masks. So we've added masks for 2020 and 2021 because of the COVID pandemic, as we raise awareness that children should not be left behind as we offer palliative care, because some children are born with congenital anomalies and they grow with those problems into adulthood. Their parents have to take care of them. Some children will have a diagnosis that is life-limiting with a poor prognosis, and these children go through a lot of suffering. The families go through a lot of suffering, and our team is here. You can see we have a big team in KNH. We are here to support the children, support the adults who need palliative care. So this year, we have a series of good activities. We've done the webinars. This is our last webinar today. Check out our social media pages of KNH. We have videos there, healthcare providers, patients, chaplains, talking about what they do for patients needing palliative care. And the patients and caregivers are telling us about their experiences before and after they were referred for palliative care. On 8th of October, we are very proud that we'll be launching our national palliative care policy in Kenya. And this will guide the palliative care practice in Kenya. So of course, we all know that policies help us to establish what we need for the service to actually reach to the grassroots, to the patients who really need palliative care. The same 8th of October is the day for us to wear hats and masks for children. We will actually do it tomorrow so that we are able to participate in the launch of the policy. So tomorrow you'll see us in hats and masks in the children's ward as we raise awareness for palliative care. So in conclusion, palliative care is about bringing hope, and hope should be brought to patients every day. So as you see your patient, there is no tomorrow. Today is the day to bring hope to hopelessness. Remember to keep hope alive for your patients and never tell them that there's nothing you can do, because there's always something you can do for them. These are some of the references that were used for the presentation. Thank you very much for your attention. We'll now welcome questions and comments.
Thank you very much, Dr. for that very informative session. Somebody is asking if they can be able to share the link or the reference to the...
Yes, the presentation will be posted to the KNH website, even the recording. We'll share the references. You can actually read some of these materials. There's a lot of material there on palliative care.
Dr. just to, maybe I'm making you repeat again, but how does a patient find themselves going to palliative? Do we have a practice of referring the patients for palliative care when they need it?
Okay, now part of the reason we are having this presentation is to encourage healthcare providers to refer patients early for palliative care. Let's not wait until when things are so wrong or when the patient is about to die is when we are referring them for palliative care. As I mentioned, our clinic is next to GFD. We are sharing a wall with GFD directly opposite the renal laboratory. So the system we use in KNH is like other specialized clinics. You drop us a consultation. Our extension is 43736. Also, when you give us a call and there are patients to be seen, we will come and review them. So on Tuesday, we do major ward rounds for the children, and on Thursday, we do major ward rounds for the adults. So when we are doing our rounds also in the ward, we get to pick up the consults for the patients who need to be seen.
So at the moment, even the people who require inpatient palliative care, they still get admitted and can be followed up.
Yes, actually, even I'm happy to tell you that we are able to admit patients from the palliative care clinic. So even the ones who are referred to us, if it's in case of an emergency and we weigh and we see the patient needs to be admitted, they'll be admitted through our clinic to the ward and we are able to follow them up.
Thank you. And then concerning culture, do you see that we have an accepting culture in palliative care from your experience? Because I'm sure you have different experience from the first world country and this country.
Okay, what I can say, palliative care worldwide, it's not just in Kenya. The reason we started even with talking about the history of hospices and palliative care is to actually understand where some of the myths and misconceptions are coming from. So initially, of course, a lot of palliative care was being given to dying patients. And as you can see, it's a modern day palliative care just started in 1967. So palliative care is also changing. Now, many patients, when they are referred, they actually go and Google what is palliative care. And some of them will say that when you are sent to a hospice, it means you cannot be cured or it means you're dying. So again, in many of our cultures, people believe if you're sent to palliative care, things are bad. Now we are emphasizing on early referrals so that we can be able to walk the journey with the patients. Because some of these diagnoses we actually know they are not going to get better. So why not start talking about that early enough instead of waiting for the time when now the patient is too sick, is when we now want to start discussing that this patient cannot get better.
Thank you. Somebody is asking, can you expound on what is end-of-life care? And what's the practice in Kenya? Maybe you can expand on that.
Okay. Now, palliative care has phases of illness. So we have patients who are stable and their symptoms are well controlled, their diseases are well controlled, and you find most of the time the interventions we are giving them is the psychological, spiritual, social support. Now, end of life, there are many schools of thought. Now, there's some schools of thought that say you begin dying the day you're born. So every day you're closer to dying than you were. Now, end of life, in scientific terms, could also be when we are sure that death is approaching. So we can see physical signs and symptoms that this patient is dying soon. So we can choose to define end of life being that a patient has a diagnosis that they're likely to die from at some point. And sometimes we can be able to look at indicators of how soon it's going to happen. And sometimes we can also define end of life care to mean that we have actually seen signs and symptoms that this patient is dying soon. For example, terminal delirium. What people in many cultures say that the dead people are calling you because the dying person is hallucinating, talking to people who have died before them. And this delirium tends to come 2 weeks before death. So in many cultures, people will say that the dead people are calling this person. But you see, so some of these are scientific or physiological symptoms that we can see. And sometimes we can start talking about end of life care from the time of diagnosis, where we are discussing about prognosis. So end of life care, of course, involves managing symptoms, talking about prognosis, talking about places of care where the patient would like to be cared for, and even now the active interventions of symptom relief or managing these symptoms that are coming around the physiological dying process.
Thank you very much. That's quite interesting. I never knew there's something called terminal delirium. Even me making me start believing in those things. How about what stage do we start family conferencing?
That's an interesting question, Susan. Actually, this morning we were reviewing our family conference tool for KNH. And one of the things that came up is we actually need a guideline for family conferencing. Family conferences, the aim of a family conference is to discuss about diagnosis, prognosis, and treatment of the patient. So a family conference is applicable at any time of the illness, depending on what you want to discuss with the family. Is it interventions you want to discuss? Is it diagnosis? Is it prognosis? So usually there needs to be an agenda or an aim for why we are holding a family conference. So basically it depends. Are you trying to establish a diagnosis? You would like the family to be involved? Is it prognosis you want to discuss? Is it treatment options?
Sorry, so Dr. And how about breaking bad news? Do we do it to children? Do we explain it to children?
Okay, children, according to our Kenyan law, children cannot make decisions and the decisions have to be made by adults, and their parents are the ones to make decisions for them and to give consent on their behalf. Now, as you heard from yesterday's presentation, it is very important to involve the child in their care. So we do break bad news to children, but we have to seek consent from their parents. We need the parents and caregivers, first of all, to understand what the child is suffering from, how we are going to treat it, and why it is important for us to communicate with the child, because that is part of the support that we are giving to the children that we are treating, communicating with them and helping them to adjust to being in hospital for a long time, to adjust to not being able to play, not being with their siblings. So yes, we do break bad news to children, but after receiving consent from their parents, and also after enabling the parents to understand where we are with the illness of the child.
Thank you very much, Daktari. Just a quick one. This is a very interesting question. Do all people get palliative care, even if they're not sick? Let's say if they don't have cancer, because I mean, we can't cure old age as well. So do they also fit in the criteria of getting palliative care?
They will get palliative care if they have frailty. So as you've seen with what we've been discussing this week, palliative care is about improving their quality of life. So if there is something within the family setup or something that the elderly person needs help with, because some of them will have comorbidities, they might not even be sick all the time, but maybe we need to support their family in taking care of them. And in my experience, I've found that as people age, when they get beyond the age of 97, we have some patients who have lived up to 100 years plus, they start to develop problems. So we help the family to cope with those problems that are coming, like their feeding will reduce, their hearing, their mobility. And it's usually distressing to the family because the family still expects this elderly person to just be able to take 3 meals in a day, to be able to participate in family events. So when they are not sick, most of the time we are offering more support to the family than to the elderly person.
Thank you very much, Dr. Maybe to take you back again, do we have guidelines for breaking bad news to children? And before you can answer, kindly allow Zipporah Ali to speak, Dr. Zipporah Ali.
Yes, please. Welcome, Dr.
You can proceed with the question while he's upgrading her. Do we have guidelines
for breaking bad news to children? Yes, we have. Okay, within KNH, we've not developed formal guidelines, but we have guidelines generally in the practice of palliative care of how to communicate with patients. So children, adults, elderly patients, we do have the international guidelines. Please, we give time to Dr. Zippy.
Now, I was just commenting that when Dr. Nikes, like Dr. Fuller was talking about family conferences, apart from us telling the patient about the diagnosis and the rest, and how, I think it's also a good time to address the patient's, the family fears, because most family members will probably maybe not have taken care of a terminal ill patient or a patient with a life-threatening illness, so they'll have many concerns and fears. And this is a good time to actually address those fears and concerns, and also to engage them in how they can be supportive in taking care of the patients, because this could be a long illness and they might have burnout and many other issues, family conflicts. So it's also a good time to address all these concerns, fears, conflicts, and also how to advise them on how they can be part of the team that's taking care of their patient. Thank you.
Thank you very much, Dr. Zipporah, for joining us. In case people do not know Dr. Zipporah, she has played a very key role in palliative care, and thank you very much for your efforts. And congratulations. I can see we are finally having the policy being launched on Friday. I'm sure your efforts has been there a lot.
Thank you. It is the effort of all of us, I think, and I'm glad that young doctors like Dr. Nafula are taking up the baton and continuing. And so I really encourage that every healthcare provider must understand the basics of palliative care, because you don't necessarily have to be a specialist. We need specialists, okay, but you really have to be first a provider as a healthcare provider, a nurse, doctor, pharmacist, clinical officer, social worker, chaplain. All these people are people who take care of a patient, and they need to understand the principles and basic, concepts of palliative care to be able to afford to give services wherever they are, where the patient meets them.
Thank you. Agreed. It's a team effort. There's a question regarding involving legal team when it comes to end-of-life care, because there's so much more than how they're going to die. Do we do such practices, right? Engage, go to the extent of also be in the engagement of how they're going to be buried and what have you?
Yes. Now, we engage the legal teams because, again, death and dying is actually more complex than just saying someone is at end of life. As I said, for some schools of thought, dying is every day. You die, you're closer to death because you were born. So the legal teams help us a lot with the legal issues, not just will writing. Actually, part of the things we study along as we learn palliative care is about the legal issues that come about. So there's issues of consent, there's issues of advanced care planning, there's issues of wills. So some hospices like Nyeri Hospice has a legal clinic where the patients come and ask patients and relatives, and they get to interact with the legal teams and ask questions about their property and things like that. And just helping patients to understand what the law provides for them in Kenya. Now, when it comes to things like will writing, of course, we discuss with patients sometimes, depending on the culture also. Some of our cultures, when you mention a will, especially if you hear your doctor mentioning, do you have a will? People start to imagine you mean they're dying tomorrow. But we also try to bring it up in a culturally sensitive way. Also, just to help the family to prepare themselves, because sometimes we have people who have hidden their properties and their monies, and then they die and the family is suffering. So we really help families and patients to have these discussions. And we've had many lawyers who volunteer to work with palliative care units and hospices to actually just help us also be versed with how to help our patients when they ask these questions.
Okay, thank you. Simon is asking about the Nakuru Hospice early 2007. He helped. Maybe Dr. Zipporah, can see you're typing. Maybe you can quickly speak about it.
Yeah, so Dr. Simon, I don't know if you remember, we came to Nakuru in 2007 when Elizabeth was thinking of starting a hospice. And I remember it was a very interesting time because we gave a CME to the team there and we had a meeting. I think you were in the meeting. And the hospice was actually given a piece of land that had the old casualty in Nakuru, which had burnt down. But I'm glad to say that you guys were very supportive of Elizabeth and her vision, and we were able to help her find funding, and she also found funding by herself to renovate the building into a very beautiful hospice, the band building. If you go to Nakuru, you will see it's actually not far from the hospital. It's actually part of the hospital complex, but they have been given that building and that compound to be able to provide services to the county. Nakuru Hospice is still standing strong and still providing services. Now we have also worked with the hospital, the county also to have a palliative care unit within the hospital. So I'm sure that they work very closely together. And so when a PMO invites you and says, yes, let's start this service, it's very important because without the goodwill of the management of a hospital or a county, you can't really set a service. And I'm very happy to see that you're attending this session and say thank you very much for your support, because we needed champions like you, especially those days when nobody knew what it was. We needed very strong champions like you to be able to make palliative care one of the services to be integrated into the public healthcare systems, the mission hospital and the private hospital as well. Thank you.
Thank you, Dr. And thank you also, Dr. Simon, for being a visionary, because it's something that will be there for a very long time. An interesting question about euthanasia. How do you handle when people ask for euthanasia, and how frequent do patients in Kenya ask for euthanasia?
Dr. Zippy, would you like to help me answer that one about euthanasia?
Hello, sorry. So first and foremost, let me say euthanasia is illegal in this country. It's still illegal in many countries, except a few countries in Europe and a few states in the US. Euthanasia is not something we do. It's not something we practice. Palliative care was actually developed as an alternative to euthanasia. When patients came and said, please help me to die because I'm in so much pain and suffering, palliative care moved in, stood in for the patient and addressed all those issues the patient was talking about, whether it was physical pain or any other physical distressful symptom, the emotional, psychosocial, and spiritual needs of the patients, because we actually have a holistic approach to patient care. And when you reduce the anxieties, the fears, and the pain of this patient, you can be very sure the next day they'll not be talking about wanting to die. It's because we fail our patients, we don't do what we should be doing for them, that they come asking for death. Euthanasia is illegal, whether it's voluntary, involuntary, passive, active, it is illegal in this country. So what you need to do is find out why the patient is asking you to let them die and address those needs of those patients. And that's why you must make sure that if they have pain, you have the right medications for pain. Whatever symptoms they have, you have the right medication for those symptoms. If they need a spiritual caregiver, because it might be all about spirituality, why have I gotten this disease? What did I do wrong? Get somebody, a spiritual caregiver to support you in the team. It might be because they have lost maybe they are the breadwinner and they've lost that in the family. Get the family, like we talked about family conferences, to understand what the patient is going through and to support them. So we shouldn't let our patients go through so much pain and suffering to ask us to kill them. We were not trained to kill. We are trained to preserve life. We might not make them live for long, but for the number of days that Dr. Esther Nafula said earlier on, whether it's days, weeks, hours, we have to put quality of life into those days, weeks, and hours. Thank you.
Thank you, Daktari, for pointing that out. It's quite interesting. I didn't know it was an alternative to euthanasia. I think it's a very good alternative. I remember reading an article once, a girl flew to another country, a Kenyan. I don't know if you had such experience where they really want euthanasia to the point that they're willing to go outside. Because you're in that field, is it something which is common?
Euthanasia. The request for euthanasia is common, but as Dr. Zippy has said, most of the patients who are requesting for euthanasia have unmitigated suffering. So you'll find that either the patient has immense pain, has social isolation, there's a symptom that is making them request for death because they are seeing that life has become unbearable. But once we are able to sort out whatever it is, then the patient is able to move on with their life and forget about euthanasia. A case in point is one lady I saw in 2015 who had a fungating wound on the breast. She got into a matatu and all the passengers alighted. She said she even offered to pay the matatu to bring her to the hospice, but even the matatu driver kicked her out. So this patient, by the time she was coming, she thought she just wants to die because she has been locked up in the house. She's stinking, nobody wants to be near her. But after we started taking care of her wound, she was happy. She went for a toilet mastectomy and she was very happy. She didn't want to die anymore. In a few cases, we've seen patients who are actually suicidal. And in that case, we need a lot of help from the mental health department. And they are again able to get the care that they deserve from the psychiatry team and the psychology team.
Yeah, agreed. There's even, I noticed the difference itself. There's a program that there's a donator wig. They usually do give them wigs and make them look beautiful. I swear it's one day, but the big difference that you can see the smile they put on, it's a huge difference. So I agree with you. Definitely, we can make their life easier without necessarily going to euthanasia. I don't see any more questions. It's really, thank you very much. Great presentation, Dr. Nafula. It's just songs of praises of you and the palliative team. So unless we have any parting shots before we close the session or anything that you feel like you really need to address. Dr. Nafula?
Yes, I do not have any further issues. So just to thank the audience for attending and looking forward to partnering and working with all these healthcare providers. We are giving knowledge on palliative care. Feel free to reach out to us if you have any issues that need clarification, and we can always share resources for you to read on these questions that are coming up, like euthanasia, legal issues, family conferences. We are a phone call away.
Dr. Zipporah, and quick question, I think it's the last question. Is it possible for us to have champions? I think probably you already have one. Maybe you can expand on that as you're passing through.
So is it about a champion in palliative care? Did you say? Yeah, we actually have a palliative care ambassador. She will actually be at the palliative care launch. She is Honorable Caroline Karugu, of the Deputy Governor of Nyeri. She has been very supportive in Nyeri. She has actually visited over 120 homes of patients who need palliative care. She interacts with patients. She's very vocal. She helped us reach the media last year to talk about palliative care. She accompanied us to go to NHIF and meet with the NHIF to talk about the need of palliative care to be covered by NHIF. So we do have a champion, but I would also advise you that wherever you are, you can look for local champions as well. You can invest in your own local county champions. Even people who have got palliative care needs are also very good champions, so that we have as many champions as we can, from the grassroots to the policymakers. Thank you. And thank you, Dr. Nafula, for a wonderful session. And moderator, thank you very much.
Okay, thank you very much. I think we have come to the end of our session today. I hope we have more champions in all counties, and we have structured methods of doing the palliative care better than it is right now. We can always hope to be better. So thank you very much, people. Have a lovely day. Goodbye.
Hi, thank you. Okay.